For those of you, though, who are flat out against vaccinations, who are trying to find data that supports your argument that vaccines are actually not safe, or that the COVID-19 vaccination has actually killed more people than the COVID-19 virus has, you got another thing coming to you. Because this show and this episode is not going to be for you. And I want you to come at me with that data too, because I have a lot more reputable data than just some hack you found on TikTok or Instagram. Speaking of which, we're now on TikTok and Instagram, so be sure to follow us. Welcome, everyone, to this week's episode of the JAFERD Cast. I am your host, Dr. Mark Pappadakis. Nobody particularly special, just another fucking ER doctor. Now, this week, we're going to be doing something a little bit different. Last week, we talked with Dr. Maggie Gaughran regarding pediatric fevers, and we actually had to cut out a segment on febrile seizures, which is basically a child who develops a seizure while having a fever. I cut it out largely for brevity. We didn't really have a lot of time to talk about it. The episode was running long, so I'm going to incorporate that discussion into this week's episode. But I also want to talk about something that's going to be a focus on intermittently throughout the show, which is going to be vaccines. When I first started talking about the show in the very first episode, I mentioned about how there are things that are going to become very political, not because they're political by nature, but because politicians and others have made them political. And unfortunately, vaccines are one of those topics. Now, for this week, I'm going to mention two vaccines, one of which we know very much about, the COVID-19 vaccine, and that has been the subject of many a paper and opinion all throughout the interwebs. But the other one is going to be about the vaccine for RSV, as well as a monoclonal antibody targeting RSV. RSV is a virus that is called respiratory syncytial virus because the virus itself goes inside your pulmonary cells, your lung cells, and causes them to die. Syncytium refers to a phenomenon where the virus doesn't necessarily get cleared right away. It creates a sort of cluster of cells, whether viral or immune cells, and your own body sometimes cannot really get to them. So respiratory syncytial virus is more or less a description of the name of the virus, where it targets your respiratory tract, creates a syncytium inside your respiratory and lung cells, and it's triggered by a virus, hence the term RSV. So that's where we're going to kick things off this week. So let's get started. So when speaking about the RSV virus, we already know that it's a virus that targets respiratory epithelium, respiratory cells that line your whole respiratory tract, including your main bronchus, your bronchioles, little smaller airways, and of course your lung tissue. That's what we refer to when we talk about your respiratory tract. Now, RSV is what we call a lower respiratory disease, meaning it primarily affects the lungs and the cells all the way in your lower respiratory tract. We call those little tiny airways the bronchioles. The larger airways are called the bronchus. So bronchioles are like the little sister, little baby brother to the bronchus. What happens with this virus is the inflammation triggered by the virus itself causes swelling. When swelling occurs in those tiny little airways, well, you can imagine the airways get smaller. If you have a child and your child has been sick with this type of virus, you may have actually heard something called wheezing. Wheezing is very common in people who are smokers. People who smoke heavily, they can develop wheezing long term, which can eventually develop into COPD, emphysema. However, asthmatics also have wheezing during an asthma attack. RSV can actually trigger wheezing as well. They develop a condition called bronchiolitis. As the airway gets smaller and smaller, air doesn't really travel through them as easily. Now, the treatment for RSV is, well, not great. It's mostly just oxygen and time. There were some studies done that thought giving albuterol might help because albuterol is a medication that is inhaled by people who suffer from COPD and for asthma to reduce inflammation and irritation of that airway, open up the airway itself, and ideally create more oxygen inflow. But turns out albuterol doesn't really do a whole heck of a lot for this type of situation. Again, last week we talked with Dr. Gaughran about vibes. Same thing with RSV, except this time it's not just about the vibes, it's about how much oxygen they're getting. So for their oxygen level to be 96, 97%, great. They look good. If they're not struggling to breathe, usually the child's well enough to go home. For those children, though, who have oxygen levels below, let's say, 90%, especially, even sometimes hovering between 90 to 92%, we usually err on the side of keeping them in the hospital, either for oxygen or for monitoring, especially if the child's work of breathing is very, very difficult. If they're grunting, their nose is flaring, if they're really having a hard time, it seems to take a deep breath, or they don't really seem to want to be able to speak or run around and do other things that kids normally do, that's usually indication for hospitalization and observation. This past RSV season, we were actually able to develop 2 new ways to combat RSV, largely before the child became infected. First is an RSV vaccine that is given to expectant mothers to create antibodies against the virus itself, so that way the child, before they're born, actually has some defense against this all the way when they come out of the womb and into the environment. There's also another type of therapy called a monoclonal antibody. For those who went through the pandemic and COVID, and for those who are also immunocompromised, you may recognize the term monoclonal antibody, as these are given to people who are either at severe risk of disease or to treat an existing disease by actually pushing in antibodies against a certain disease. In this situation, RSV is one of those types of viruses that we actually have antibodies for, and we can give to certain populations. So why am I talking about this? Well, as of this recording, on May 20th, 2025, a report that came out 2 weeks ago on May 8th, published on the CDC's MMWR website, Morbidity Mortality Weekly Report, shows data regarding the hospitalization of children hospitalized with RSV. In this study, we're actually looking about the hospitalization rates among infants and young children after being given the RSV vaccine, either the antibody itself or some maternal antibody vaccine before they were even born. So they looked at data between October and February 2024 to February 2025. For those of you who are listening to the podcast on either Spotify or any of the other platforms, you can go to the YouTube page and actually see what I'm showing to the people on YouTube with regards to the study itself. So let's take a look at the data talking about the RSV virus, hospitalization, and its overall effectiveness. We're talking about actual hospitalization rates, not necessarily getting the virus itself when it comes to RSV, which is important because some vaccines prevent getting the virus completely, like the MMR vaccine. Others just prevent severe hospitalization and death, such as a COVID-19 flu vaccine and now the RSV vaccine. Let's take a look at some of the data here. So if we scroll down, first of all, we have to understand the RSV vaccine itself is given to maternal mothers who are going through their 32nd to 36 weeks of pregnancy, usually between September to January in most of the United States. The reason is because RSV season typically occurs during the winter months. You don't really get it during the summertime, so if you're expected to deliver in, say, July, you're not really going to need it until the wintertime comes anyway. In that situation, now you're going to be talking about the monoclonal antibody, whose name is called nirsevimab. Anytime you hear something ending in MAB or AB, it's a pretty good chance of talking about a monoclonal antibody. So the monoclonal antibodies are given to infants 0 to 7 months, and all children all the way up to 8 to 19 months, assuming they're at increased risk of RSV. Premature infants, those with respiratory issues, spina bifida, all these things can weaken the immune response, which is why they are considered to be more high risk than your typical toddler. If we come down and look at the data itself, there was a 28 to 43% reduction in hospitalization of these infants. And what they're looking at for comparison is the 2018 to 2020 RSV season. 23 to 43% reduction in hospitalizations is insane. That's almost half of infants that would normally be hospitalized actually managed to stay out of the hospital. Again, we're not talking about infants who were actually got RSV. We're talking about infants whose RSV disease was so bad they had to come into the hospital and receive oxygen, high flow, all these other therapies. The reason why they're talking about the 2018 to 2020 RSV season is largely because in the interim times of the pandemic, data was actually hard to come by. There was a lot of social isolation still. So this past year was the first time we really had good data among the last RSV season. And it was also following a very severe RSV season from 2023 into 2024. Further looking at the study, it shows that the National Immunization Survey data shows that an estimated proportion of U.S. infants 0 to 7 months protected by ED vaccination increased during the 2024-2025 season from 30% in October to 66% in February. This coincided with a reduction in 2024 to 25 RSV-associated hospitalization rates. Now the question becomes, how do we know that this is actually due to vaccination and not just maybe a less severe RSV season? Well, it turns out they looked at that, and higher RSV-associated hospitalization rates during 2024-2025 compared to 2018 and 2020 was looked at in children in older age groups, who were, of course, ineligible to get the RSV vaccine. As a result, these groups actually showed higher hospitalization, meaning that children who were actually older and not eligible to get the vaccine were hospitalized more compared to the children who did get the vaccine and younger. Despite the lower age and the higher risk of severe disease, they're actually hospitalized less compared to a quote-unquote healthier child who was older who ended up needing hospitalization. And something you're going to find as the show goes on is that it's very difficult oftentimes to determine who is going to be high risk for severe disease and who is not. We talk about who's high risk for disease, and typical ones come out like people who have diabetes, people who have immunocompromised systems, those who have cancer. But understand something. You are healthy until you are not. It sounds pretty obvious, but the reality is anybody at any time is capable of developing a severe infection or a severe disease without any risk factors whatsoever. And then suddenly, now you have a risk factor for further severe disease. Let me give you an example. If a woman develops an ectopic pregnancy during their first or second pregnancy, they are now considered to be at risk for further ectopic pregnancies, just on the idea of alone that they have already had one ectopic pregnancy. Before then, they're at normal risk, just like any other woman in the same age group. But because they already had one pregnancy that was an ectopic pregnancy, they're now at risk for more ectopic pregnancies. So the idea that you're healthy until you are not is something that we in medicine like to look at. This is why we in medicine stress the importance of public health, because somebody may be completely healthy up until they get an infection, a virus, that all of a sudden causes long-term problems. And there are long-term problems with many other viruses out there, not just RSV or COVID or the flu. We're even talking about the common cold. People sometimes get something called Guillain-Barré, which is an inflammation to the nervous system leading to weakness and sometimes temporary paralysis. There's no way for us knowing who's going to be at risk for that or not, so we try and educate people on the idea of public health and prevention. We now have to talk about vaccines in general. So again, as of today, May 20th, the FDA just came out saying there's going to be new requirements for COVID-19, who can get them and who is not going to be eligible. So speaking to the timeliness of this episode, the New England Journal of Medicine just came out with an article written by Dr. Vinny Prasad and Martin Makary regarding the COVID-19 vaccination. In this article, an evidence-based approach to COVID-19 vaccination, both of them discuss the rationale for actually not wanting people who are otherwise healthy to get the COVID-19 vaccination. Well, mostly the boosters. This article itself is not actually a research article. It's a sounding board piece. Those who read the New England Journal of Medicine, the Journal of the American Medical Association, all these pieces, basically, all these publications have sections where you can write letters to the editors, sounding boards, whatever, that actually aren't research focused, but more or less just opinion pieces. So this article showed up today, picked up by the major news organizations, talked about their requirements for the COVID-19 vaccination. So what does their article actually talk about? Well, it effectively boils down to, did somebody who is over the age of 65 or under 65 benefit in the past from getting a COVID-19 booster? Their answer is, well, we don't know. We need to study this a little bit more. And at surface level, that makes sense. However, this is where the intersection between common sense and critical thinking tends to come into play. Rather than continue the recommendations and advise people get the COVID vaccine booster as needed if they want to, they are now removing it so that people who actually want to get it may either A, have to pay more out of pocket because insurance won't cover it, or B, may not be able to get it at all. They're also saying that current evidence suggests very young children are still at risk for getting COVID-19, but not as much as somebody who's over the age of 65. Therefore, in their view, let's not authorize it for their usage. And here's where I want to be very clear on something. The whole idea of public health, the whole idea of vaccination, herd immunity, terms that you've heard about much over the past 5 years, is to prevent the spread of disease from one person to another and to prevent the emergence of more severe infections. The COVID-19 influenza, all those boosters are designed and tailored to what we believe to be the strongest form of the virus present at the time or will occur. That's why flu vaccines are seasonal, meaning that they look at data from the southern hemisphere when they had their winter, what the most likely strain of flu will be, and tailor the vaccine to that. Like with COVID-19, they want to give some people some immunogenicity as soon as a virus lands, usually during cold and flu season, which is your late fall and winter months. Now, because the recommendations are changing so that only people over 65 will be eligible to get this, that means that younger people, such as myself, your friends, your family, even your children, will either A, will not be able to receive this vaccine, or B, have to increase more of the cost because insurance will not cover for it. Their logic, though, presents a bit of a conundrum. What if you are somebody who lives in a household and cares for their elderly parent? What if you're in a household with a very young child who's actually immunocompromised? Yes, they are eligible to get the vaccine, but if you are not, you still have a greater risk of transmitting it. Vaccination doesn't just help your symptoms, it also reduces transmissibility. Not to a large extent to the point where it's 100%, but to some degree where if your body is able to clear a virus faster than it can develop symptoms, you can now actually reduce your risk of transmission. Families who have older adults living in their house are not all eligible to get the vaccine. Instead, you have families who are now going to be high risk and low risk who are going to be incompletely vaccinated. And putting the burden of disease onto the older generation as opposed to everybody, where it's everybody's responsibility, is honestly not fair. Just because somebody has been vaccinated doesn't also necessarily mean that they will create a proper immune response to the vaccine. Instead, the vaccine may not work for them. No vaccine is ever 100%. Even the MMR vaccine, the measles, mumps, rubella vaccine, has not been shown to be fully 100% after 2 doses. It's 99%. And sometimes your immune system wanes over time. You go on steroids for a condition, you develop another infection, another illness, and all of a sudden you get diseases that you thought you were immune to or that you never had a problem with. One classic example is shingles. Sometimes people who are so stressed, who are on steroids for whatever reason, develop shingles, which is a reactivation of a dormant virus that causes the chickenpox. And those who have had shingles can tell you it's pretty goddamn painful. The same model applies for vaccines for regular viruses. Somebody getting a vaccine for the flu or for COVID may not develop the immune response necessary to prevent further infection. As a result, they rely on other people around them to now help protect them from getting infected. This is what we call herd immunity. The idea that you have 1 or 2 individuals surrounded by a herd of people who now can prevent disease transmission into their own lives. The idea of a family member being solely responsible for their own protection is pretty ridiculous, especially in the world of medicine where we know things are not 100%. Now, one of the other claims that Makari and Prasad made in their article are such that vaccine hesitancy has actually increased because of the vaccine, and therefore, this is one of those ways where we can further reassure the American public about this. However, it's not really 100% true. And this article talks about that, where childhood vaccines were actually falling way before the pandemic even started. In fact, as we all know, that the pandemic really only exacerbated an ongoing issue with vaccine hesitancy. The MMR vaccine started to fall during the pandemic, even before the COVID-19 vaccines were available. And you can even see here in this article, again, for those on Spotify and Apple Podcasts, I apologize. But for those on YouTube, you can even see the data dropping here. In between 2011 to 2015, there was a decline. At this point, vaccines weren't even a political hot button topic. You can see here, basically during 2011 to 2015, vaccine rates really dropped for reasons that could have been due to social media, influencing, who knows. But all of a sudden, they came back up, thankfully, in time before the pandemic hit, and now suddenly they're dropping like sticks. So why are we talking about vaccination right now and vaccine hesitancy? Well, the World Health Organization in 2010 actually listed vaccine hesitancy as one of the top 10 global health concerns. And a report in 2021 from the CSIS, the Center for Strategic and International Services, basically came out saying that vaccine hesitancy was a big issue for national security. If you think about a country that has a reduced immune response to any type of virus that can cause severe disease or even death, and I'm not talking about COVID-19 or measles, I'm talking about something like smallpox or polio. All of a sudden, another country knows this and says, hey, we can generate an actual vector that's going to inflict death. And another country knows this, they can potentially launch a bioweapon just of smallpox in an unvaccinated population that now can wipe them out while saving their own troops who have already been vaccinated. So the idea that vaccination is a military concern as well as an economic concern and public health concern doesn't really surprise me. It really shouldn't surprise you either. Vaccine hesitancy is one of these issues that we deal with many times during our clinical practice. And though we talked about it a little bit today, we're going to get into it a little bit next time when I talk with an infectious disease specialist as well. I'm not against somebody who has questions on vaccines. A true vaccine skeptic, in my opinion, is somebody who has legitimate questions, who's concerned about the side effects and adverse effects of not just vaccines, but any therapeutic. And to be clear, the things that we do in medicine do have side effects. Medications that we give, treatments we institute, procedures that we do, from the minor to the major, all have the risk for complications, for adverse effects. Somebody who wants to question those, in my opinion, is not wrong. They're legitimate questions that we have to ask about these therapeutics, about medications that are coming off the line, that we always want to know, what is the safety profile? Is this safe for my child, for myself? Can something bad happen that is actually, like they say, is the cure worse than the disease? The vaccine denialist, however, is somebody who refuses data that's already put in front of them. We're going to talk about data. We're going to talk about the way vaccines impacts, the way medications, all these things in medicine we do impact our patients positively, and have honest conversations about the way they negatively impact our patients' lives. However, I want to be very clear about something. Vaccines as a whole are a public health godsend. They are effective, they are safe, they've been widely used for decades. And yes, no vaccine is 100% safe. There are people who do get reactions to it. There are people who do suffer side effects. I'm not saying they're not. However, when we talk about risk to benefit, the benefits far outweigh the risk. Already, we're seeing cancer rates drop in older adults from things like HPV. We're seeing people get hospitalized less with the flu. And of course, we're seeing data from the RSV vaccine showing reduction in hospitalization in our nation's children. These are prime examples when we say an ounce of prevention is worth a pound of cure. There are always going to be questions and concerns regarding a new therapeutic and a new way of tackling a known problem. And that's to be expected. And for those of you who have questions, for those of you who have concerns, that's what this show is going to aim in part to do and help alleviate. Not just myself, but with other experts as well. For those of you, though, who are flat out against vaccinations, who are trying to find data that supports your argument that vaccines are actually not safe, or that the COVID-19 vaccination has actually killed more people than the COVID-19 virus has, you got another thing coming to you. Because this show and this episode is not going to be for you. And I want you to come at me with that data too, because I have a lot more reputable data than just some hack you found on TikTok or Instagram. Speaking of which, we're now on TikTok and Instagram, so be sure to follow us. So on that happy note, let's bring back Dr. Maggie Gaughran to talk about febrile seizures. And the reason why I'm doing febrile seizures in this episode is actually because RSV can trigger fevers and can trigger febrile seizures. So let's take a dive and see what we're talking about. I do want to mention, and see if you can talk about febrile seizures.
Yes.
So febrile seizures, like I said, are one big component of emergency medicine visits, calls to pediatricians, and having seen them in action, they're scary.
Yes.
I can understand why parents are like, my child
like,
just had a seizure.
They had a seizure. Why aren't you doing it? Yeah.
What are you doing? Why are you not doing anything?
Yeah. And again, it's hard to, explain to a parent that, because this is something that happens, right? So this is a thing that happens in kids, right?
But it doesn't happen to every kid.
No, it doesn't happen to every kid.
And that's something that I try to communicate. And then the questions begin, like, well, does my kid have a seizure disorder?
Right, is it
now?
my kid? Is it right? And there are different, it gets into kind of the nitty gritty, but there are things that we consider like a simple febrile seizure, right? So these are specific age groups, like 6-month-olds to usually we say within like the 5th year. Those are kids who can get these simple febrile seizures, which is like a generalized seizure, the thing that people see in the movies with the shaking, right? And it usually lasts anywhere from a couple seconds to a couple minutes. But like as a parent, it lasted for 7 years. It's like the longest thing, right?
It just keeps going.
Time stops. And so the less than 15 minutes, which is a very long time to have a seizure, but that time generalized in that age group we consider as like a simple.
And it's not just 15 minutes of like one big seizure.
Right.
One thing that you have to compare that people don't understand is it's 15 minutes of intermittent seizures too. The seizure starts, lasts for a minute, stops, and they're a little confused, and then it starts up again.
Right. And then we
consider that one seizure episode.
Right. And then there's, these more complex seizures or febrile seizures, which are, going to be like one body part. It's going to be out of that age range that we'd expect. They're going to be prolonged, those kind of things. So I'm going to leave those as something else. But the simple ones, the simple ones are not a form of epilepsy, right? So they're not a seizure disorder. They are response to the fever.
What about the fever triggers it? Do we know?
Yes.
That's my first question. Do we? Okay.
We do know. And it has to do with the neurons not being fully myelinated. It has to do with cytokine storms.
That's cytokines, mitochondria, myelination.
Yes, right. Wow. Exactly. Things you don't want to really be thinking about. But basically, like, children's brains are not that good. Right? They're not that good.
That's, you know what?
So
perfect.
That is the way that I can explain it. They aren't that good. They're not fully formed yet. And so they're a little bit more susceptible to things that can make their brains go, when there's something like a fever.
Yeah. Yeah. Is it the temperature? Like do they hit a target and then that's a problem? Is it the rise in temperature?
So I've always been told it has more to do with the rise, because some kids, they can hit a 104 fever and not have a seizure, and some kids can hit a 102 fever and have a seizure. And the most frustrating thing to tell a parent is we don't really have a way to know if it's going to happen or to stop it from happening. Right.
And that's the thing, because they think, oh, well, I gave my child Motrin and they still seized.
I put them in the bathtub in freezing
matter.
cold water, right? Those things, it's not going to stop it. Or, we give Tylenol, Motrin because it makes them feel better, but it doesn't necessarily do anything else.
Does my child now, because they had a febrile seizure, are they at increased risk for having more seizures? Are they more an issue for epilepsy later?
Right. So if they had simple febrile seizures, then there is not a great increased risk for them having any kind of epilepsy in that. Complex febrile seizures, different, but there is an increased risk of them having another febrile seizure, but not epileptic seizures.
And it's important to denote simple versus complex. So, obviously we're not going to get into the criteria per se.
Yeah.
But if your doctor says this was a simple febrile seizure, that's a good thing. Oh, okay, fine.
Right. Still scary. So scary.
Still scary. Right. 100%
so
still scary.
Yeah.
If it's a complex febrile seizure, understand we're also not just discharging these people either.
Right.
They're getting
a
workup very similar to a much sicker thing. So, and then it's up to the doctor to understand, is it simple? Is this complex? But parents can still be reassured that a seizure with a fever is okay, provided there are certain criteria there that it's up to the doctor to determine.
And I think it's just something, that we as doctors understand is very scary. And I think parents get frustrated because it seems like we're not getting afraid enough. I'm not scared enough,
Yes. Don't just stand there, do something. We give Motrin and Tylenol to make the child feel better. Does that mean I need to give my child Motrin and Tylenol around the clock? Because
good question, because that is something that we used to do, right? Especially if we had kids with febrile seizures and then we were sending them home, we were like, okay, give Tylenol, Motrin. And again, research, so important, has been coming out showing that this doesn't really change the risk of them having another febrile seizure.
All right, thanks again to Dr. Maggie Gaughran for coming on and talking about febrile seizures with us. That wraps up another episode of the JAFERD Cast. A bit of a different format this week. Again, the RSV vaccine is given to pregnant mothers who are in their 32nd to their 36th week of pregnancy, usually between the months of September to January, just as RSV season is kicking into high gear. And the monoclonal antibody is actually given to infants who are in their first month of life all the way to their 7th month of life. It's one of the reasons why the RSV vaccine is not given to older children is because as children and adults get older, their airways actually increase in diameter. As a result, the inflammation that is caused by the RSV virus doesn't actually cause the whole airway to constrict nearly as much, so they don't get hypoxic. With regards to the recommendations from the FDA, the COVID-19 booster will only be recommended to those ages 65 and older, or those who are at high risk of disease, those with diabetes, chronic immune problems like MS, lupus, and of course those who have neurological issues such as stroke and potentially morbid obesity. Thanks for joining me on this episode. As always, if you're in the healthcare field and you want to be on the show to discuss topics in healthcare, please feel free to reach out as well. Or if you have ideas to talk about, you can email to me at jaferdcast@gmail.com. As always, don't take my word for it. Do your own research, talk to your own doctor, because at the end of the day, I'm just another fucking ER doctor. Make good choices, everybody, and stay safe out there.